Hi everyone. I was tasked to debate the con side of family members being considered partners in care delivery and critical care. I'd like to apologize as my video camera is not working, so please enjoy this photo that I often look at during meditation. I would first like to thank my classmate and opponent Sarah for putting forward a strong debate and rebuttal. I would also like to thank the rest of my colleagues for taking part in the debate and hearing everyone's opinions related to this issue. Now, I would like you to imagine yourself, just for a moment, in an unfamiliar and high-stress environment with medical professionals asking you to make critical and possibly life-changing decisions about your loved one with no time to think about it or to prepare for it. How would you feel? Would you feel prepared to make these necessary decisions? This occurs much more often than you would think in critical care. In critical care areas such as the emergency department or the intensive care unit, patients are often left unable to make decisions for themselves due to injuries or illness. Consequently, families are left to make these decisions. These decisions can often hinge around complex and potentially distressing issues, such as the duty to preserve life, the right to a peaceful and dignified death, and the balance between length of life and quality of life. When patients are admitted into critical care areas, their loved ones often feel anxious, overwhelmed, stressed, and panicked, just to name a few emotions. This is where highly skilled and trained professionals come in to make quick life-saving decisions. Although my colleague presented many great points about why it is important to include family members in the decision-making process in critical care, the question still remains, how exactly do we do this? After thoroughly browsing through the Society of Critical Care's most up-to-date guidelines on the implementation of family-centered care in critical care, their newest guideline does have 23 recommendations on implementation, but all 23 were listed as weak recommendations by the Society of Critical Care itself. How can individual practitioners or organizations rightfully apply these weak recommendations to practice? Have they been standardized? In addition to the lack of standardized guidelines, barriers continue to exist in the implementation of family-centered care in the critical care areas despite years of research on this topic. In a review published in the Nursing Open Journal in 2019, they identified 3 barriers to implementation of family care in critical care: individual barriers, interprofessional related barriers, and organizational related barriers, mostly due to the critical care environment. The critical care environment itself is known to be unwelcoming to family members due to the limited space at the bedside, packed and overflowing waiting rooms, and lots of essential life-saving equipment. These treatment areas are meant for life-saving treatments and interventions, not for family comfort. This brings us back to our scenario at the beginning. As I mentioned in my debate, the most important decisions we make as healthcare providers revolve around the patient and trying to give the patient the best possible outcome. By including family members who are feeling pressured, anxious, and stressed in critical decision-making, we could potentially be causing more harm than good. In closing, until further research is conducted and there are guidelines in place on family-centered care in critical care areas, it is best to keep distinct roles and allow healthcare providers to care for the patient and continue to provide patient-centered care. I challenge you all to place yourselves in these family members' shoes, without medical knowledge, without time to prepare and make these decisions. How would you cope? Would you feel comfortable making these decisions? Thank you.